Welcome to Health IQ. I'm Dr. Siegel. Today we have a special guest, Dr. Katherine Vadasdi. She's with the ONS Group in Greenwich, Connecticut. She's an orthopedic surgeon and director of women's sports medicine. Welcome. Thank you for being here.
Thank you for having me tonight.
So tell me about women's sports medicine. Tell me how you got into that specialty and how it differs being an orthopedic surgeon working in that specialty.
Absolutely. So women and men have similar sports injuries, but there's certainly a difference in some of the specific injuries that females have versus males, and some of the ways that we approach preventing them and treating them. And so when I got into orthopedics, I had a love for sports and athletics, and so I went in the direction of sports medicine itself and did a fellowship in that. And then as I started working with a lot of my patients, I recognized the difference in a lot of the injuries that I saw in some of my female patients and how we could approach them primarily at the younger age, really in the adolescent age. I think it's so important to help prevent some of the injuries that we see in some of our adolescent female athletes, ACLs, and other injuries like that. And so I really took an interest to how can we in our practice work together as a group, and we have male doctors, female doctors, all working together, but really coordinating the care. And often that is focusing on how many sports the athletes are doing, what we can do preventatively at school, at their club sports, with their nutritionists at home to make sure that they're eating appropriately, getting appropriate sleep. But we're really looking at a comprehensive sort of overview of what the athlete is facing, how we can treat the injury that they've come in to see us for, and then how we can prevent them in the future.
And are there a lot of physiological differences that would cause a female athlete versus a male athlete, especially at the adolescent age, to have possibly different types of injuries? Are there reasons for this?
There are. The first difference is as we get into puberty, males tend to have an increase in testosterone and females have an increase in estrogen. And what that does for female athletes is it makes them more flexible, which for a lot of athletes makes them a better athlete. They have more flexibility in their shoulder if they're a swimmer. So it does give a benefit, but it also means that they're a little bit looser. Their joints are a little bit looser, and that can put them at risk of getting ankle sprains, ACL ruptures, instability in the shoulder. And so there are certain anatomic differences that we're not going to change the endocrine side, meaning we're not going to change the estrogen. We want to allow obviously puberty to develop, but what we can change is some of the muscle development, because as boys get testosterone, they get an increase, they start getting stronger, their muscles start getting bigger, and they don't have to focus on it as much. But I think that we can spend some energy helping our young female athletes that as they're growing taller, to help them really build the muscle strength and balance to prevent them from developing some of those injuries that we see.
So the flexibility issue is one of the kind of common denominators that can cause some of these issues. Mm-hmm. Now, what about diet and nutrition? Do you find that if younger female athletes are not eating properly or possibly not getting the right amount of calcium in their system, or mm-hmm. how much does that come into play, and how much of that can help them prevent some injuries potentially?
Sure. When I see patients, particularly adolescent athletes, I always speak with them and their family about the injury, so whatever body part they've come to see me for. But the other two parts that I really focus on are sleep, because I really think you can't train a tired body, and a lot of our young athletes they're student athletes, and so they are trying to balance their academics, their sports, and oftentimes multiple sports. So that's the first thing that I really emphasize, is that they have to figure out, with anything that I may add on to them in terms of physical therapy, we've got to make sure that they're still getting their sleep. And then the second thing is their nutrition. And for a lot of kids, they're rushing out the door in the morning, they're not getting enough nutrition and balanced meals throughout the day for a regular young growing adolescent. On top of that, they need extra nutrition or nutritional attention if they're athletes and they're out there running, swimming, doing other sports that require extra calories, extra electrolytes, and hydration. Hydration is another really important thing that we talk about. Are they getting enough water throughout the day? It's not a great idea to just...
Most kids probably aren't drinking enough water
at all. They're not at all. And so I always look at the kids who come in with a water bottle in their hand, and I always sort of congratulate them, because it's really important that they're getting that nutrition, hydration, and sleep. And so we do discuss all of those factors. There are certainly some sports that are higher risk, ones that have more of an appearance presentation for girls, whether it's dance and things like that, where they put the pressure on themselves or from the sport they're being put on.
Dance and gymnastics and tennis and skating and some of these kind of individual sports tend to have that high risk, high stress, high intensity background, and that becomes a problem for the children, the family, and it's I'm sure you see this a lot. So, you know, how do you balance that with those families and those kids and the athletes?
I think it's one of the hardest discussions to have. I try not to focus at all on weight, because it can be overweight or underweight. I try to focus a lot more on nutritional balance and making sure that we're getting 3 meals, and I really try to focus on 5 meals a day. I mean, you may be having your 3 larger meals, 2 snacks, but focusing on making sure that the athletes know that if they want to perform at the level that they're hoping to, at their potential, that they need the nutrition, they need the hydration, the sleep, to get their bodies there,
and
they
the
can't
rest,
do it.
right?
Exactly. Those are all important.
Yeah, one of the main things is probably the amount of hours and the amount of some of these dance young ladies. They probably practice more than the average lacrosse or baseball or even hockey players, and those repetitive hours, I think, are really come into play, whether it's gymnastics or dance or any of these skating, same thing. So you're trying to balance those hours and the amount of repetitive stress on top of all the other problems with nutrition and lack of sleep and lack of hydration. You know, that's kind of a recipe for disaster in some cases if you can't balance that.
It is.
Yeah.
It really is. And so that's why I think sometimes when I see an injury, I take it back to even before the injury. Where was that balance for sleep, for nutrition, for your training, for your academics, and how can we get that into play and get that into a good balance, right, so that we can get you safely onto the field or in the pool.
So you're the director of women's sports medicine, but truth be told, a good part of your practice is male and female. So what are the more common problems that you're seeing without your practice? Whether it's male or female, because you work on shoulders and knees and elbows as a specialty. So
absolutely. So I do see a lot of male and female adults and adolescents. Probably the most common injuries that I see throughout the day would be for the shoulder, a rotator cuff injury, so whether or not it's just inflammation or tear. The elbow, I see a lot of epicondylitis, which is golfer or tennis elbow.
Yeah.
And then for the knee, a meniscal tear. So those are probably the 3 most common things I see throughout the day, and then a lot of variation and things that can come with that.
Right. So I think people as orthopedic surgeons, they don't always expect to have surgery. They obviously want to have a diagnosis, they want an evaluation, they want to know what they can do. But truth be told, a lot of stuff they see is repetitive in nature, chronic in nature, not always a surgical case, percentage-wise in terms of like your patient population.
Absolutely. It's one thing that we really focus on at ONS is that a large percentage of our patients do not go on to have surgery. And that is really the way that we've set up our practice, and that we have the ability to do that in terms of each one of us as an orthopedic surgeon. We're not just seeing patients who have already been indicated for surgery. We are seeing everyone who has an elbow pain for a week, had a ski injury last week and ruptured their ACL, or something that's more chronic. And so a lot of my practice, I spend as much time with my patients discussing all of the non-operative options. So how can we get this better without surgery is always my first discussion. There are certainly some injuries. If someone injures their knee skiing and ruptures their ACL and has a meniscal tear, there's not a lot of discussion of the non-operative options if they're a 20-year-old active athlete. But if you come in and you have pain in your shoulder and it's inflammation around the biceps and rotator cuff, we spend a lot of time discussing what are all the things that we can do before even doing an injection. We can do physical therapy, anti-inflammatories, modified posture, and things like that. So there are a lot of things that I do during my day that are not surgical discussions, for sure.
Right. So a medial meniscus or a meniscal tear, I think everyone's kind of heard that term at one point talking to a family member or anyone that's been involved in sports. Do you feel like there's sometimes, not controversy, but there's been some studies, sometimes the effectiveness of certain types of procedures for meniscal tears or from meniscectomies and versus repairs, and how do you feel about all of those variations of repairing a meniscus or cutting out meniscus or the long-term effects, and in some rare cases you can actually do a transplant of a meniscus. So just kind of touch on sort of how you evaluate it and where you go from there. So
it's definitely one of the most common injuries I see is a meniscal tear. And it's interesting because patients come in and almost everyone has had a friend who has had a meniscus tear of some sort. And a meniscus tear, medial or lateral, but more commonly we see medial, can be a very different injury depending on what type of tear it is, if it's an acute tear versus a chronic tear, where the tear is in the meniscus, if it's on the outside edge or the inside edge, and that really is has an effect on it, whether or not it can heal, and that determines if we can fix it or just clean it out. But ultimately my approach is kind of gone in two directions. One is for the younger patient, the meniscus is really important. It provides stability and cushioning for the knee. And so it does one major thing, and that's prevent against arthritis.
Like a shock absorber.
Shock absorber. So we want to preserve as much of the meniscus on both the inside and outside of the knee as possible, particularly in a young patient who has good cartilage on the ends of the joints and doesn't have any arthritis. So if I have a younger patient who comes in and has even a smaller meniscal tear, we'll often recommend, and I'll often encourage them to, let's actually go ahead and operate on this now, where I can go in like a small hangnail, trim off that edge, and preserve the rest of your meniscus. So it's small now, but that way I can preserve the rest of your meniscus without putting you at a big risk of getting arthritis in the future. Like a hangnail, that meniscus flap can continue to pull and get bigger and bigger, and you have to remove whatever is torn for the most part in a meniscal tear unless we can repair it. But most tears that we see in sort of an adult population, we trim it out, we don't fix it. And so for those, even a smaller tear, I will go in there, trim it out, patients do great, and then I've saved the rest of that meniscus. And I think that's really important when you're looking at a younger athlete who we can preserve the cartilage on. For an older patient who is starting, and older changes every day as I get older, I think, you know, that age, it's more really the age of the knee. So it's not the age of the patient, but it's really what the knee looks like. So if I have a 40-year-old or an 80-year-old with the same knee on exam and on MRI, I may treat it similarly, but it's really what the rest of the cartilage looks like. So if I have a patient who comes in, they injured the inside of their knee, they have pain there, but the rest of their knee does not look great, meaning the cartilage on the ends of the bones, underneath their kneecap, on the inside of the end of the knee, are pretty worn, then I might not encourage them to have surgery right away, even if it's that same small meniscal tear, because I know I may go in there and clean out that tear and the tear looks better, but they're still going to have that cartilage wear, and you can actually make that worse because they can actually start to become more symptomatic from that arthritis or wear of the cartilage. So in that patient, I'm a little bit slower in terms of going in surgically. I will try an injection and physical therapy and everything we can, because I know that I can make that meniscus better, but I can make the overall knee actually worse if they have wear of the cartilage. So we have different approaches depending on how the injury occurred, where the injury is in the meniscus, and what the rest of the knee looks like.
All right, but most of the time it is, in that case, it tends to be a surgical option, but not all the time. If it depends.
For a younger patient, right. It's uncommon that I have a younger patient with a healthy knee and a meniscal tear, and I tell them not to have surgery.
Okay, because you feel that the longer-term damage.
We're looking at that long-term, protection of the cartilage in that knee, and then.
So you see patients with arthritis and different problems within their knee, and do you do any of the Synvisc, Orthovisc, or things of that nature as part of your practice?
I do. There are a lot of different brands, and I use, and honestly, right now, insurance dictates which brand, but it's hyaluronic acid, and it's basically lubricant, and studies are variable in terms of the outcomes, but I use them for a lot of patients who have some wear of the cartilage, and I think it's more sort of mild to moderate arthritis where patients do best, and it can be one injection or a series of 3 injections. Sometimes you'll do a steroid injection with the hyaluronic acid, and it works as a lubricant, and I have many patients who get the injection and they feel phenomenal, and the amount of time that it lasts can vary. Right. It can be 6 months, 12 months. I've had patients come back 2 years later and say, wow, that worked great, can we repeat it? So it's a really good solution for someone in that earlier phase of arthritis.
Mild to moderate,
Exactly.
And does it matter which compartment of the knee it is, or not necessarily?
Not necessarily. I think it's more how much damage or injury to the cartilage there is.
Okay. And another common thing is patellofemoral syndrome. A lot of runners, a lot of different younger adolescents get these types of. Just tell the audience what exactly that is, and what causes it, and usually that can be treated rather conservatively for the most part. So
patellofemoral, the joint is underneath your kneecap. Your kneecap tracks the end of your femur bone, and we like to see it track smoothly, just like a train does on train tracks. For a lot of more females than males, but for a lot of athletes, that kneecap does not track perfectly. And if we catch it at a younger age, we can help rebalance some of the muscles around the hip and around the knee so that we get that patella or kneecap to track better. And that takes the stress off of that joint. as that continues, if a patient continues to have a lot of stress in that joint because it's not tracking perfectly, they can start to develop arthritis there. So if I see a 15-year-old with patellofemoral pain versus a 50-year-old, it's probably a very different looking joint. A 15-year-old, the cartilage is going to be smooth, and the approach may be a little bit different, and that we really want to focus on.
This is different cartilage, just so they understand. It's underneath the patella versus the meniscal.
Exactly,
cartilage, right?
It's different cartilage than the meniscus. Right. There's cartilage at the end of the bones, and when that starts to wear, that's what osteoarthritis is. So again, we want to preserve the meniscus, we want to preserve the cartilage at the end of the bones. So I see a lot of young girls who have this, and part of the reason is, again, as girls are growing in height, the balance of that kneecap can sometimes go off, so they have maltracking of that kneecap. And for a lot of those athletes, it's a relatively simple solution. It's not surgery, it's not injections, it's nothing invasive. It's a matter of rebalancing some of the muscles, primarily around your hip, which is something that's missed a lot. It's the muscles on the outside of your hips that help keep your knee directly over your ankle and take the stress off the front of the knee. So by re-strengthening those muscles, rebalancing the hip muscles, the quad and hamstrings, we can get rid of a lot of that pain. Those same exercises are also the exercises that can help prevent ACL injuries. So those are great exercises that we can...
We're talking like the quads and the hamstrings and
quads,
IT band issues.
And hip abductors and external rotators are really important, because when we look at lunging, squatting, we know that females tend to be a little bit more knock-kneed, so their knees fall in as they lunge or squat or land from a jump. Those put you at risk of getting patellofemoral symptoms, and they put you at risk of getting an ACL rupture. So we can do a lot of work with our younger athletes, really even 7, 8, 9, training them how to strengthen those muscles on the outside of the hip as well as the quad and hamstrings, so that when they're landing, when they're squatting, lunging, their knees staying over their ankle, it's not dropping in, and that helps prevent against both the anterior knee pain, which is that patellofemoral pain, or as well as an ACL injury.
And as an orthopedic, your relationships with other providers, physical therapists, other strength and conditioning coaches, I think that is probably a pretty strong, important part of you understanding what they do and they understand what you do, and working together as a team to try and prevent surgeries in some of these patients, prevent further injury, and just try and prepare these athletes for their sports, basically.
Absolutely. I work with a lot of personal trainers, as well as physical therapists, as well as the trainers at school and coaches, so that we can help introduce some of these programs into the schools, so that the girls and really a lot of the athletes can do it as part of their warm-up. They can introduce some of these strengthening exercises. We work with a physical therapist if someone's already injured, but we work as a whole team, because again, if we can prevent a lot of these injuries, it's obviously better for all of our athletes, and that takes a team approach.
Yeah, and then let's talk about the shoulder a little bit. You talked about rotator cuff earlier. There's different types of problems you got with rotator cuff, impingement syndromes and tears and tendonitis. What tends to be the more common? And even people hear a rotator cuff tear. Is that always, again, typically have to be surgery, or it really depends on the patient? If they're in their 50s and they're kind of done with their athletic career, so to speak, can the other muscles kind of help activate and not worry about that one tendon that's torn, unless there's a lot of pain, of course. But I've seen patients where they may have tears, but they don't have pain. So they can't get their arm above their head, but they don't really care. So those are the kind of cases where you look at them a little bit differently.
Yeah, the shoulder's a neat joint. So the rotator cuff is a group of 4 muscles, and they're tendons in the shoulder. There's 1 in the front, 1 on top, and 2 in the back. And those muscles are important for keeping the shoulder stable, so keeping the ball centered on the socket, and then also moving your arm around. So raising your arm above your head, behind your back, across your body. And the most common injury I see with those is inflammation, so tendonitis. Overuse, and whether or not that is an electrician. I see a lot of overhead workers, so their arms are constantly over their head, causing inflammation in the rotator cuff and in the bursa up on top of the rotator cuff. And it can also be in overhead athletes, tennis players, basketball players. We see a lot of that as an overuse injury. Most of those in the younger age, so 40 and below, don't have a tear. It's more inflammation. It's a matter of calming down the inflammation and then helping strengthen the rotator cuff muscles. A lot of us who are athletes and we think we lift and we do a great job of strengthening the muscles in the front. So our pec, our biceps, we're not as good at strengthening the small muscles around our shoulder blades and the rotator cuff muscles in the back of the shoulder. And so we tend to be a little out of balance, and that puts a lot of stress on the shoulder itself and actually puts us at a higher risk of getting impingement, which is when you raise your arm up above, you're pinching the rotator cuff between the 2 bones. So probably the most common thing I see is just inflammation, no tear. And so for that, we start with physical therapy, anti-inflammatories, any of the NSAIDs over the counter, rest,
right.
Stop doing stop doing what's bothering you, which most patients don't want to hear.
Exactly.
So I have to say, okay, fine, don't stop, but let's not do overhead tennis for the next week. Or you start to ask them, how many times a week are you doing it? Let's cut out twice a week and see how we can back off. But normally physical therapy works really well to help strengthen, again, rebalance those muscles. If it's more of an acute injury, so you fall skiing or you have, more of a trauma, then it can be a tear. And then as we start to get more 40s and above, we start to see more rotator cuff tears, where that inflammation can either progress to a tear or just overuse over time, the rotator cuff tendon just starts to wear and you get a tear there. And the question is, how often do you have to fix those? Well, a lot of them, you're right, I don't fix. If it's a partial tear, we start with anti-inflammatories, physical therapy, sort of the same program as if there were no tear. I do watch those carefully, though, because we know that they progress onto a tear most of the time. The natural history is a partial tear or a small tear will get bigger. They don't heal on their own and they don't get smaller. So if I have a patient...
there is no recovery of the tendon necessarily. I mean,
they don't heal on their own. So with a small partial tear, I will certainly start with physical therapy, a more conservative approach, but I will follow those patients at least 6 and 12 months. And if they're still having pain or weakness at 6 months, I'll actually repeat the MRI, because sometimes we'll see that partial tear has gone on to become a full tear. And that's one that you want to fix, because we want to fix those again when they're small, because it's much more reliable in a younger patient with a small tear that the rotator cuff will heal versus an older patient with a huge tear that's much less likely to heal. So we don't want to have to over-operate, but we also want to have our patients have a better outcome. And if they have a small tear, it's a lot better for them. They'll be in a sling for a shorter period of time, they'll recover faster, and they have a higher likelihood of healing that rotator cuff than if we wait until it's much bigger.
Some other common things people hear about is labrums and bursts, like you mentioned before. What are the differences? A labral tear is sometimes a little bit more surgically inclined, or depending on the patient again?
Yeah, it depends. So some labral tears are traumatic. So if someone dislocates their shoulder, what they most commonly do is tear their labrum, either in the front or back of the shoulder. In a younger patient, again, often we fix those. That is definitely a hot topic in terms of debating whether or not you fix it after the first dislocation with the labral tear, if you let a young athlete dislocate a second time. So that's debated a lot.
Pitchers, this could be all different types of athletes.
It could be a pitchers, it could be any type of athlete, but that's normally that's more of a traumatic injury. So if it's a football player who dislocates his shoulder on the field, he tears his labrum, whether or not you let him finish the season after a little bit of rest and some physical therapy, do you let him finish the season, or do you have to go ahead and fix that labrum? That's definitely up for debate. It depends on the size of the tear, the location of the tear, their symptoms. If they can't get back, obviously, you don't let them do that. And you want to let athletes get back as quickly as they can, but we want to make sure they're doing it safely and they're not causing long-term damage. And some of the research shows that if we let someone continually have instability events in their shoulder because their labrum is torn, then they're going to be predisposed to getting arthritis at a young age. So we want to avoid that. Older athletes with labral tears tend to be more degenerative and just kind of wear and tear. Those we rarely have to operate on. So that is much more physical therapy, strengthening the muscles, taking the stress off of the labrum. Sometimes we do operate, but not as commonly in that situation.
Okay, so in terms of orthopedic surgery, the trend has been minimally invasive, less invasive, smaller incisions, robotics. How do you see the next 5 to 10 years in your specialty even progressing, maybe regenerative medicine, stem cell medicine? What do you think might be coming down the pipe for possibly not having to do, not any surgery, but less and less surgery potentially? What do you see in the literature?
Well, certainly since I've started, the push has been in arthroscopy, and the techniques that we can do, some of the rotator cuff repairs that we couldn't do, 10 years ago where they were really advanced, are pretty standard. So any shoulder rotator cuff repair, I'm doing all arthroscopic. So I think that in terms of arthroscopy, we'll continue to advance in terms of the techniques that we can do. Some procedures that we're doing open, we'll start to do those arthroscopic as our techniques and instrumentation and implants improve, and the technology allows for smaller entrance into the joint. So I think we'll continue to see improvements there and our ability to just do more and more. But I think really the hot topic and the next area that we want to see growth is a lot of the biologics. So how can we get a rotator cuff tear to heal without surgery? Is it PRP? Is it stem cells? There are a lot of things that are out there being studied. We haven't quite figured it out. None of them work perfectly and have completely, resolved or figured out that issue so that we can do that. But we are using a lot of them. Stem cells we'll use with a fracture that's not healing, and they work really well. So there are a lot of things being studied, and I think that's really where we want to go. Certainly in a patient with arthritis.
And how are stem cells? How are they being implemented? I think people would like to know. Like,
Oh,
is it
absolutely.
an injection type of procedure, or?
So right now, I'm using it primarily in the operating room setting. Some people are doing it in the office. I think it can be aggressive, but you basically take some of the stem cells from your pelvis primarily and inject them back in. And so the best studies are in fracture healing, and fractures that have not healed, called a non-union, to inject them into that fracture and really stimulate healing. Or in an area that you're worried that's compromised, the blood supply to the bone, will inject stem cells as an injection and basically a tube to help stimulate that area to heal. There's certainly research being done on stem cells and arthritis, and I think that would be very exciting if we can figure out what the best injection is for arthritis, whether it's the shoulder, the knee, the hip, the hand, any joint. Right now we try steroids. We do some of the hyaluronic acid that we talked about before, PRP, and stem cells. And there are pluses and minuses of all of those, but we certainly don't have any injection right now that is going to regrow the cartilage.
Right, reverse the arthritic process, and then, joint replacements obviously being the end result of a significant, arthritic joint, whether it's your hip or knee or shoulder in a lot of cases. So it can be, problematic. But if you can reverse arthritis in the world here, it'd be quite remarkable.
It would be.
Or surely regenerate certain types of joints, even if it's, like you said, some of the smaller joints or the larger joints over time. We want to put Stryker out of business, of course, but
but if we get to a lot of these joints at an earlier time period, right, with more mild or moderate wear, and we can figure out how to stimulate the body to regrow that, I think that's where there's a lot of potential. And when there are small defects, we have a lot of injuries who. Kids and adults will have a small defect in the cartilage. So it's more like a pothole versus the whole road is really worn. And figuring out how to fill that one pothole in and having it regrow cartilage, even if it's a slightly different type of cartilage, is huge, because then that patient is less likely to go on and wear out the whole joint, whether it's a shoulder or knee. And so we spend a lot of time on those smaller cartilage injuries in a younger patient to figure out how to fill those in and re-stimulate the cartilage to grow.
And I think what's important lifestyle-wise is, we tend to always look at the problem but not the solution, even as a society. When you're dealing with patients who, take on too much sugar, tobacco, alcohol, lack of sleep, other environmental toxins, it degrades the body. So, telling people to live healthy lifestyles, active lifestyles. Injury can always occur. There can always be a trauma. There can always be, but there's also a lot of prevention that we can promote out there, where maybe our bodies don't break down as quickly in some cases. So I think just being involved in healthcare and talking to our patients like you do, especially when you see an adolescent population, working with them at a young age and steering them the right way for proper diet, proper nutrition, proper hydration, rest, and they will have better physical bodies as they get older. I think that's important, what'd you say?
It's a huge part, particularly for the younger, but even for a lot of the adults I see. I have a lot of patients
weight,
who
we didn't
come
discuss weight on joints.
Weight is a big one. I really do have a lot of patients who come in who have something that aches a little bit, but they don't have a tear. I'll often just say, you don't even need an x-ray. It's a little sore, but I think they just had something that was a little sore that sort of stimulated them to want to go in and see someone and talk to someone. And it's often about, I used to be an athlete, I used to do a lot, I work a lot, I don't have time. How do I figure that out, and where do I start? Do I start running? Do I start lifting? What's the best way to balance? And so I have that conversation with a lot of they're athletes who have taken a rest from an injury or from life or from some other reason, but they want to figure out how to get back in and figure out that balance. And it can really be any age group. It can be an 80-year-old who's recovering from a hip fracture, or a 20-year-old who's been studying super hard and hasn't had the time. But I always focus on certainly the sleep, and I think that's a huge part in the nutrition, and weight I think is an important part of it. But I also think that there are different types of training. And so probably the biggest thing that we see, particularly in a lot of our younger kids, our younger athletes, is they're doing the same sport all the time, 7 days a week, 12 months of the year, and that's just way too much overuse. So one thing I try to really direct my athletes, do different sports, and whether or not you're a kid doing in season or you're an adult, break it up a little bit. So you're doing some strength training, you're focusing on strength and balance, and you're focusing on endurance or cardiovascular. And so if it's a younger athlete, I'm telling them to do different sports. If it's a,
Sure.
Sort of a
well, the single sport athlete these days
is dangerous. But even for the adult, I have plenty of adults who all they do is run 7 days a week, and they wonder why their knee hurts. And so, I'll say to them, I think running is a fine sport for most people. I think it's a great sport. But break it up a little bit. Most of us can't tolerate the exact same sport every day for our whole lives. It's too much. It's going to wear. If you swim, swimming is another great sport. But if all you do is swim 7 days a week, you're probably going to have shoulder pain. And so I do try to encourage patients, spread it out. Do some cardiovascular. If you want to do cardiovascular every day, that's great. But try to break it up. Do some biking, do some swimming, do some running, do cross-country skiing, mix it up.
The opposite of all this is the sedentary person who's sitting in a chair 8, 10, 12 hours a day, or the person on the computer, hunched over, on the phone, on the iPads. A lot of these kids just start having neck and shoulder problems inadvertently just for repetitive stress for doing the wrong things all day long.
Right.
So there's extremes all over the place, and I think that's a balance, and I think that's the most important thing.
Absolutely.
That we've discussed here today. So just get everyone out there and see their doctors and orthopedics when they need it, but really work on prevention, work on understanding how to become just a better physical person. Reduce musculoskeletal pain and discomfort. So
yeah, I think there are probably 3 or 4 things you can do during the day that we can all do to reduce stress and prevent a lot of injuries. And I think you said that the neck and shoulder for a lot of people who are at a desk or computer all day, but even a lot of our students who are just on their iPads, on their computers. If we just bring our shoulder blades back and bring them up and we do little neck shrugs, you can do small things like that that can help prevent a lot of us have neck and shoulder pain. So we can do a lot of small things that I don't think we're necessarily good as a society to spend the time to just focus on those preventatively. They can make us all happier, healthier, more productive, and able to enjoy more of those
sports. Maybe avoid some surgeries if possible. But
absolutely.
Anyway, it was a pleasure speaking with you. It was a great show, and I think our audience definitely learned a lot. Thank you for joining us. I'm Dr. Siegel, and we'll see you at the next show. Bye-bye.